So my talk is going to be differentiating between glaucoma and neurological cause of optic neuropathy. As you said, as we know that glaucoma is the commonest cause of optic neuropathy, and I'm going to do that by having some cases. A 46-year-old male, this is a representative case with a gradual loss of vision in both the eyes. He has been on treatment for primary open glaucoma. Visual acuity is 612 and 69. Intraocular pressures are borderline, and he has open angles. So are there any red flags here with a 46-year-old male with loss of vision? Well, the red flag here is the age. Anybody who is under the age of 50 and has a significant cupping, unless you know why that patient has developed glaucoma, you should be looking for neurological cause. I'm not saying that glaucoma cannot start below the age of 50, but if you have a patient, young patient who has a reduction of vision, and if it's not fitting in glaucoma, you should be looking for a neurological cause. This is the picture of the optic disc. Now, second case scenario. So that was age. Second red flag, a 56-year-old female with a gradual loss of vision in both the eyes. Visual acuity is 2/60 in the right eye, 6/36 in the left eye. What is the red flag here? The red flag is profound visual impairment. Glaucoma on its own in the early stage of the disease is not likely to present with visual impairment. It can happen much later in the disease. So these are some of the studies which proved that Jonathan Trope found that 12 patients with a compressive optic neuropathy had a loss of central vision as obviously as a presenting feature. While Greenfield et al. Found that visual acuity less than 20/40 should 77% in his series had cupping which was non-glaucomatous. One more case scenario. So one was age, second was visual impairment. Now we have the 70-year-old male with the visual acuity of 1/60 in the affected eye, and here the red flag is the NRR. While the patient does have a large cup in the left eye, the affected eye, but if you look at the neuroretinal rim, and there is an arrow here, that is pale. Now that's again not a feature of a cupping of this size. So patient with a large cupping, if it's because of glaucoma, the neuroretinal rim will continue to remain pink till very late in the disease. So the red flag in that case would be pale neuroretinal rim. Now what do we do next? How do we confirm? Now we already are suspecting in cases like this where you have a pale neuroretinal rim, a large cup, and you feel that, oh, this may be a non-glaucomatous cupping. How do we confirm? What do we do next? Pupil for RAPD would be a very objective test which will confirm if it's a non-glaucomatous or a neurological optic neuropathy. So the question is, of course, can glaucoma also have RAPD? For glaucomatous cupping or for glaucoma to have an RAPD, there has to be a difference of more than 0.43 in the cupping. That means the neuronal loss in both the eyes is so asymmetrical that the RAPD can be because of glaucoma. The other two signs which can help you to differentiate between glaucoma and neurological disease would be color vision. Remember, glaucoma is primarily an optic neuropathy which affects arcuate fibers first. While if there are signs of papillomacular bundle affection, that does not happen in glaucoma, not at least early in the disease. If patient who has been diagnosed as having glaucoma, not a very advanced glaucoma, has a color vision deficiency which cannot be accounted for by other causes, you probably are looking at a non-glaucomatous optic neuropathy. The other pointer can be in your visual fields. If you have a foveal threshold available, and if you have a reduction of foveal threshold early in the disease in cases of glaucoma, you know that maybe you are looking at a non-glaucomatous cupping. So RAPD, color vision deficiency, and foveal threshold will point towards effect on a papillomacular bundle, which generally would be spared in glaucoma at least early in the disease. So this is one of the study which can we look at the optic disc and differentiate between glaucoma and compression? Well, optic disc hemorrhage, presence of hemorrhage was specific for glaucoma. Family history of glaucoma, 96% of the patient, you say that okay, that patient is likely to have a glaucomatous optic atrophy, versus pallor of the neuroretinal rim, which will go more towards a non-glaucomatous cupping. What we are worried about, of course, is a compressive optic neuropathy. Let's look at one more scenario, one more red flag. So we looked at the age, pupil, color vision, appearance of the optic nerve. Now this is a case of normal tension glaucoma with a normal visual acuity. The pressures are 16. Patient has minimal blurring of the vision. The cup are shown here. There is a large cupping, there is no real notching or vertical elongation, which is very apparent here. However, when you do the visual fields, obviously because the confirmation of glaucoma would be by appearance, the intraocular pressure, appearance of optic nerve, and the visual fields. If you do a visual fields and if you find a field defect like this, where you see in the left eye, the predominant defect is mainly on the temporal side, which again is not really very typical of glaucoma. Glaucoma typically would start on a nasal side, nasal step, and it will break into an arcuate scotoma. While if you have a predominant temporal defect, you know that you are probably dealing with a neurological cause of cupping or an optic neuropathy. So the next red flag would be a visual field which is not corresponding to the appearance of the optic disc. If they are not matching, you know that you are dealing with non-glaucomatous cupping. So what if the normal tension glaucoma by itself has become a little controversial entity? Do we really have a disease entity like that? So there was a debate to say that can we now just do neuroimaging everybody whom we diagnosed as having normal tension glaucoma? And one study found that 3.8% of the patients who were referred for evaluation of normal tension glaucoma actually had compressive lesion, and normal tension glaucoma was a red herring. Versus there was another study where they said, well, not really. Everybody who was diagnosed as having NTG were having NTG. Obviously, debate probably will veer more towards logistics and financial reasons rather than a scientific reason. This was a very nice study which was done by our colleagues at Shankar Netralaya, by Dr. Ronnie George and Nikhil Chaudhary. They looked at 6 patients who were being treated as patients with glaucoma, and they turned out to be neurological issues, and they went back to the chart and said that, oh, what were missed out, and what was missed out was really startling. Right from the beginning, they said that 4 out of 6 patients, the treating physician failed to attend to grossly asymmetrical vision loss. The morphology of pupil, which is in all 6 patients, that was missed. So if a swinging flashlight test was done, probably they would have found an RAPD and would have treated the patient differently. Failure to document optic disc morphology just beside vertical cup disc ratios. There was no mention of the appearance of neuroretinal rim. Failure to correlate visual acuity with the cupping of the disc, or in fact, shockingly, half of these patients never had a visual field. So a borderline pressure, large cup, and the glaucoma diagnosis was made. So these were the mistakes which, if you avoid, then it's not really difficult to differentiate between glaucoma and neurological disease. So who would really need a neuroimaging if you are treating a patient with glaucoma? Presence of headache or any other neurological symptom, obviously you would look for neurological cause of glaucoma. Decreased vision, fluctuating vision, a vision loss, which is, I'll take half a minute. Atypical visual field for glaucoma, like visual field which respects the vertical meridian, which is predominantly central or temporal. Atypical rate of progression of vision field loss, because glaucoma is not really, it's very rare for glaucoma, unless it's a narrow angle glaucoma, it's very rare for glaucoma to present with an acute event or a very rapidly progressive event. When pallor is more than cupping, or there is an asymmetrical cupping which cannot be accounted for by the general examination.